All right, this is the first treatment approach for your neurological patients that we were talking about after the sensory stim, and this is called NDT, neurodevelopmental treatment. Just a little background on it. It was developed in the 1940s to initially treat kids with cerebral palsy, and it's based on observation of patients with a CNS damage or a CNS issue. Basically, the theory says that the patient is unable to control the impulses and then produce a resultant um, muscle coordination or contraction to do the activities that they need to do. It was the first time really they noticed that tone was an issue and that the patients would move in abnormal movement patterns, not synergistically like we would normally move. So what they really wanted to do was develop normal, volitional, automatic, very smooth reversing reactions. So that's kind of what this whole theory is for NDT. Um, it's really the quality of the movement, eventually the speed of the movement as a whole, um, how fast can the patient perform it, how fast can they understand it, um, those kind of things. Um, what do we want to do? Again, make them independent of us, of course, right? So not requiring any feed forward, not requiring any feedback. Everything is automatic. They don't have to think about it. They don't have to focus on it. All that stuff happens again like we normally would function. Um, what do we do? We need to look at our patients. So again, I will definitely say that evaluation is not part of your skill that you can do as a PTA, but constant assessment and reassessment and reassessment and reassessment of these patients is critical. They change by the second. I mean, but certainly by the treatment, definitely by the day, but absolutely sometimes by the second. Tone kicks in, tone goes away. It's a very serious issue. We are constantly focused on promoting normal movement patterns and inhibiting abnormal movement patterns. We facilitate, we inhibit, we elicit, we are constantly reassessing where things need to be. Remember, I talked to you about approximation, building tone, increasing tone and muscle movement and ability, and proprioceptive feedback and kinesthetic awareness, all through approximation. Approximation is weight bearing. That's exactly what approximation is. Having gravity influence your body is a great way to get them to build tone and eventually build strength and all that kind of stuff. Overlapping is huge, and basically, well, we'll talk about overlapping in a minute. Cognitive, emotion, movement, perception, all that sensory stem stuff. Again, we can't treat a patient if they're super, super upset. I can't teach you anything if you're bawling because you missed a test, right? You're not even going to listen to me. All you're doing is focusing on that F you got, F you got, F you got. You're not listening to what I'm saying. So I've got to get your sensory state prepped and ready to take the information that I'm trying to give you. Overlapping is basically all those rules we kind of talked about before. It's critical in development. In other words, a baby needs to be able to use their upper extremities and their trunk and head control, and they all kind of develop at the same time. But some things develop just a little bit before the other. So like number two, posture control precedes controlled movement. So we have to be able to stand there and use stability before controlled mobility, right? You're getting a pattern that all of this stuff goes together. We don't wait for perfection at one stage to develop another one. If so, we would be there forever. But we will constantly kind of go in between the phases and in between the things and in between the task to try to make sure that they reach a level of perfection or as close to perfection as they can possibly get. It says challenge carefully and gradually decrease manual cues. We talked about that before. Again, we need to kind of challenge them. We need to push. We make it just attainable, but it needs to stay right where it challenges them but can be successful. The higher we work them, the more functional they're going to be. Um, in other words, if the patient can stand, why not work them in standing? Because standing is going to help sitting posture, sitting control mobility, sitting musculature, everything. So work them at their highest functional level, but it may not be all of the treatment if they don't do super well at it. Maybe we'll only spend a minute and a half standing, but if we don't stand them, then we don't really challenge them or do any good if they can stand, right? Again, I really won't go over most of this. We'll talk a lot about it in lab, because we really kind of already, talked about this in the previous PowerPoint that you should have watched, the motor control behavior PowerPoint. Muscle tone varies, range does not, and all that means is they may be high tone, they may be low tone, all that kind of stuff, but the amount of strength they have to move in a certain range really doesn't vary that much, right? They don't go from being a 1 out of 5 to a 3 out of 5 in 3 days. It takes a long time to change strength. Range comes from strength, not tone. So we have to really get tone, like I said before in the last PowerPoint, right to that level that's in the middle pretty much, so we can go ahead and teach them the things we want to teach them. Again, I want you to read these and go over these 5 basic components to normal movement. These are not necessarily in any order. However, all the rules of development do go into effect here. So, what do we say? Does trunk control come first or does head control? Does midline orientation come first or trunk control? Well, I don't know and I don't care, right? They're overlapping. That's what we just said, right? So I don't care what order you list these out in the test. I don't care if you know what order to pick them out in a lab practical. What matters is that you do know the developmental stuff that we talked about. So, do you have to stabilize the patient before you can ask them to move? Do you have to make sure that they can hold their trunk and head in a good location before you ask them to weight shift? Do you understand that they need midline orientation, which means finding the middle of where they're supposed to be standing, like we did with the prosthetic patient? Do you understand that they need to understand where the middle is before you start moving them left and right? So as far as 1, 2, and 3 are concerned, well, they all need to happen at the same time. And then you can start with 4 and 5. That's really what I want you to get from it, not whether or not trunk comes before head, head comes before trunk. I do, again, still also want you to read these. I will talk to you about this particular one because it is a little dicey sometimes. What a postural set is. It's the total body response to every thought. What does that mean? That means if I'm going to be sitting with both of my feet on the ground and both my hands on the mat, and you want me to raise my right arm to reach for a cone that's you put on a table that's up high, well, I don't just raise my arm without tightening my trunk, right? So everything starts in the central body. Everything starts proximal to be able to do distal activities. So that's how we have to treat our patients, right? We have to work proximal before we work distal. So a postural set is initiated in my opposite hip, my ipsilateral scapula, and then my arm raises to grab that object. But everything is trunk control, right? And I can't free up my hands and I can't free up my legs if I don't have that. Definitely know this slide. Movement patterns in the trunk include the ability to move anterior, posterior, and that means a pelvic tilt as well. And you need to find out in your body what activities need a posterior pelvic tilt and what activities need an anterior pelvic tilt. We have to do lateral motion, and that's not leaning from one side to the other. The ability to separate one shoulder from the other, shoulder separation, that sounds weird. What that means is to be able to have one shoulder move separate from the other, where the other one can stabilize and one shoulder can disassociate. And that really has to happen before rotation can happen, where the entire trunk can do a combination of A, B, and C. Hello?
Hey, sweetie, what you doing?
Working. What are you doing?
At, at the college.
Yep,
Oh, I'm sorry.
that's okay.
Are you there with kids?
No, I'm just
Just,
recording PowerPoints, trying to get ready for next week.
oh, wow. I'm sorry.
That's okay. What are you doing?
Getting ready to lay down.
You sound sick.
I am sick. I'm
Sorry.
feeling horrible. Huh? Me too.
It's been going around. Ashlyn had sinuses and something sinus infection, and then Bobby did, and then I did, and now you do.
Jeez. And what did y'all take? Anything?
None of us took anything. It just passed in about 5 days.
Oh,
Yeah.
and it stayed with you for 5 days?
Yeah, it did.
Crap. Crap.
Yeah.
Okay. Well, is there anything I can do for you tomorrow? I am going to get out and about of some.
Not that I can think of. I appreciate it though.
Anything I can do to help you do what you're doing now?
No, I'm just lecturing into the microphone, so
Okay.
just
All right.
lecturing.
Okay.
I
Well,
appreciate
I'm
it though.
sorry that I bothered you.
Oh, you're
Yeah.
not. That's fine.
Okay. I just wanted to talk to you for a minute and tell you I love you.
Well, let me know if I can run any errands. Why are you getting out if you're sick? You gotta work?
Well, I'm hoping I'll feel better. Yeah, I do need to work tomorrow. If not tomorrow, I need to work Friday, but I think Friday's weather's going to be pretty bad. Are you going to Branson tomorrow?
Eureka. Friday.
Eureka.
Eureka on Friday.
Oh. Oh.
Yeah, we changed it to Eureka from Branson because it's cheaper.
Oh. Okay. Well, that's good. That gives me one more day because I want to get you a little cash.
No, no, I don't want any more cash. You did enough at Christmas. I appreciate it though.
I want you to have money to blow and not worry about.
No, it's not. It's fine, really. It's fine.
Yeah. Mm. Okay, we'll try to get home at a decent time.
Okay, I'll
You've already
do.
missed that.
Yeah, I know.
Yeah. All right, sweetheart.
All right, let me know if I
I
can do
love you.
anything for you tomorrow.
Oh, let me know if I can do anything for you.
Mm,
I'll
you're
be all right.
you're sick. All right, I love you.
I love you too.
Bye.
Bye.
A patient can only obtain midline orientation if they're aware of how their body feels. Um, just because we see a patient sitting crooked doesn't mean they have midline orientation deficit. They could just be sitting poorly because they don't have the strength to sit upright. They could be sitting poorly because they are used to sitting that way in the wheelchair. I mean, anything can happen. You really can't um, determine whether or not they have midline by just looking at them. You really need to get them in a posture where they don't have backrest and they don't have side support, and really assess them and in their ability to stay in midline, be moved out of it, come back to it, that kind of stuff. For obvious reasons, people need to be able to find where their center of gravity is over their base of support, because that's the position that we are most stable. So if they can't find that position, we certainly can't work on them moving in and out of it. A lot of times when these patients are left in this asymmetrical or weird position too long, their body, their mind relearns that this is correct, and they will constantly default to that position. So again, it's not like the prosthetic patient who is worried about putting weight over there or knows that they're not on there because this feels weird because I haven't been over here in a long time. Your neurological patient has no idea. So when you shove them back to center, they're going to feel like you're pushing them over. Like you're pushing them to the left or pushing them to the right, and they're going to fight you. So that's not the way that we get our patients to go back to midline orientation. And we'll talk about treatment strategies when we're in lab together. Once we get their nice midline and base of support, then we can work on them shifting front and back, left and right. So again, we start in the sagittal plane, we move to the frontal, and then to the transverse, of course. So we start with flexion and extension, we do a lateral bend, and then we work with rotation. Where we put our hands, like I said, we'll talk about in lab. The head moves in response to the trunk. In other words, if you move the patient's trunk over to the right, the head will follow, right? It's not going to stay looking left. If we turn the patient from supine to sideline, the head's going to go in the direction that we move them to sideline. So the influence of the trunk is stronger over the head than the head over the trunk. In other words, if our patient is laying supine and we make them look to the right, the trunk doesn't move that way, right? Just the head does. So that's kind of you understanding the first two, where they're, like I said, I don't care which happens which, but I do want you to understand that the trunk certainly has more influence over the head than vice versa. Head control or riding reactions or head movements happen when the trunk is displaced. Again, when the trunks move, the head responds, not vice versa. So sometimes if we want to work on some head control, we can displace the trunk a little bit and make the head move in the area we want to. And again, we'll talk about all this in lab. Use of the limbs for movement. So, are we treating a patient that needs the limb for movement? Does it need the limb for support? Weight bearing, of course, is the posture that we'll treat them in first. So in other words, they'll have bilateral upper extremity and bilateral lower extremity support when we first try to develop stability. We got to have that ability to bear weight before we can move them around and do things, right? We do want to keep in mind that the upper extremity weight bearing is light. We don't want them to lock the elbow. We really want them to use the musculature. So just what we're talking about with the prosthetic in the parallel bars, when we didn't want them to lock out on their arms and really just use their arms to hold all the weight and not ever really put weight on that prosthetic limb, it's the same thing with this patient. We want the arms not to be locked. First of all, that makes it easier to hold because an isometric contraction is easier to hold than a concentric or an eccentric contraction, and we want this patient to use their musculature. So it's never done with a hyperextended knee, it's never done with a locked elbow. Again, we work movement patterns proximal to distal, trunk out. That makes sense, right? We've talked about that several times now. This is what I was speaking of a little before. Assessment and management constantly overlap. We inhibit, we facilitate. You can't superimpose normal movement on abnormal tone. Again, we've talked about all of these things. Make sure you understand this slide as far as treatment is concerned. We'll talk about these things one by one. Our touch, we do open hands, light pressure. We grade input based on how the patient responds, and what that means is, do we need the sensory stim? Do we need to remove it so they don't get used to it? Do we do significant exteroceptive sensory stuff? Do we do proprioceptive sensory stuff? How strong is this patient? How much pressure do I give them? That kind of stuff. It's a constant assessment of what you feel under your hands. Your key points of control, again, proximal to distal. Make sure you move it around as much as possible, but if you want to facilitate certain things, you'll have to touch in certain areas, and again, we'll teach you those things. But where does this patient respond best? Grade even when releasing the cue. Don't just remove your hand. Do it nice and slow and controlled. Repetition is key. The patient will respond to that. Learn to use your own body more. This will really help you as far as your fatigue level is concerned. Use your whole body, not just your upper extremities. You're going to get really, really tired. Your back's going to start hurting. You really need to learn how to position your body so you're in the most functional body mechanic position to treat them effectively without tiring yourself out. Definitely need to move slowly and give the patient time to respond and participate. You need to pay attention to how the patient is acting. You need to watch every detail, their breath, their color, their understanding. Look for understanding in their actions. Look for understanding in their speech. Look for understanding in their eyes. Nice and slow, controlled at first, then increase speed as patient gains good carryover. Don't do it for them. Make them do it and be patient. You have to sequence the task. You have to build on the task before. It's very important, like I said, to teach them, just like a baby, to roll, to push up on all fours, then to crawl, then to cruise, then to walk, right? You have to follow the sequence and the guidelines. Here's another chart for you to absolutely memorize. We've already talked about these things. You have to structure them easiest to hardest with neurological patients. We've really already talked about the verbal cues. Okay, so we'll get to this point. Really, this is where we're going to start. I want you to read. I'm not even going to record the rest of this PowerPoint because you have this as a traditional PowerPoint. But I want you to, we're going to begin lab here when we do this segment. And I'm going to teach you each one of these things as we are in lab together. But I do want you to read the rest of this PowerPoint so you understand these tasks, because what you should do before you come into lab is practice each one of these techniques yourself. Roll to the affected side, roll to the non-affected side, do what it says. Bring up your own leg, bring your arm across your body, that kind of stuff. See where all this action happens as you do all of these activities. You see how your body works as you do supine to sit to supine, as you do sit to stand, as you do your transfers. All of this stuff. You need to review each one of these. See what happens when you do an anterior pelvic tilt. See what happens when you go back into a posterior pelvic tilt. All of these things I want you to make sure that you've got down before you come into lab. So again, you don't necessarily need to do these on somebody else. I just want you to sit there and see what your body needs, what musculature, what happens first, what contracts contralaterally, what contracts ipsilaterally. How is it contracting? Is it concentric? Is it eccentric? Is it isometric? On your body for all of these activities. And then in lab, I will teach you how to facilitate them in somebody else. But first you have to understand how they feel on your body. Okay, so let's talk a little bit about CVA gait. They have a significant problem with weight bearing and ambulation. Certainly a fear of falling, because they know that they don't have the musculature or the sensory ability to move and do the things that they need to do. Of course, then if they do fall, they don't have the speed of the balance reactions or the riding reactions or any of that kind of stuff to stop the fall from occurring. So what would we do as far as presentation of all of these things? Well, we can use the sensory stem to calm them back down, but what you're going to do with your CVA is going to look a lot like prosthetics. This should look very familiar to you. So first we're going to have them stand up and just maintain their balance, right? Can you just stand there? That's all I need to see. That's static balance in standing. Then I'm going to ask you to weight shift. Do the weight shifts look familiar? Right? Just like prosthetic. Small weight shifts first with the affected lower extremity anterior. That's the only difference, right? We used to shift from the prosthetic to the good leg. This time we're going to shift from the good leg to the bad leg. Why? Because it's easier, right? It's easier to weight bear on the good leg. With this patient, remember, we have to start easy and work harder. So all the same cueing that you do is the same for the CVA, only we don't remove the upper extremities like prosthetic. So drop that out of your thought, because very often one of their upper extremities is already affected and non-functioning anyway. So it really does us no good. Basically what's happening is we're going from unilateral support to none, and that's way too difficult for them. So we really won't do the removal of arm thing. You need to memorize these deviation PowerPoints just like you did prosthetic, and highlight over any of them that you don't understand and ask me those questions when we start class. Again, if you guys don't ask questions about not understanding why this cause would cause this deviation, I will assume that you understand muscularly why this is happening.